Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted enough time to answer as many questions as possible. Today's webinar, Why Do I Feel Lousy After Treatment of My Pituitary Tumor, is presented by Dr. Kevin Ewan, a neuroendocrinologist at the Barrow Neurological Institute, and Dr. Andrew Little, a neurosurgeon and the director of the Pituitary Center and the school-based program at Barrow Neurological Institute. Please hold, there will be a brief delay while we change presenters. Thank you. Dr. Ewan, can you please unmute yourself? We can't hear you. I'm so sorry.
Okay.
Okay, thank you.
Okay. Thank you everyone for joining in. My name is Kevin Ewan and I'm joined today with Dr. Andrew Little, my colleague at the Barrow Neurological Institute. And today we will be talking to you about the topic of why some patients still feel generally lousy after having treated their pituitary tumors. Oops. And these are our disclosures. Okay, I'm just trying to. Okay, so why do we treat pituitary tumors? I think the objective is pretty clear, and we've listed here three main objectives. One is it is necessary for the preservation of health and quality of life, and also eventually to hopefully reduce excess morbidity and mortality, especially in certain types of functional pituitary tumors where the excess morbidity and mortality is generally increased. These kinds of treatments could include typically either surgery, medication, or occasionally radiation. Following surgery, we do acknowledge that there is a good number of patients who generally recover from their treatment of their pituitary disorder. And overall, most of these patients do report of a better quality of life after having had these kinds of treatment. So the goals of this presentation really is to explore the possible causes of why some of our patients don't generally achieve the type of quality of life that they desire after having undergone what apparently is successful surgery or even effective medical therapy. In the process also, we also would like to discuss about how one can differentiate between what normal recovery is in terms of setting the expectations for the patient, and also what pertains to be red flags. Several reasons why patients may not necessarily fully recover, or at least they perceive that they don't fully recover after surgery or medical therapy or radiation to their pituitary disorder. It could well be that some of these patients have functional tumors, particularly Cushing's disease and acromegaly, where these conditions tend to be around for a long time, where there's generally a delay in the diagnosis, And so there is often a lingering effect and permanent bodily changes that can occur following the prolonged exposure of excess cortisol and growth hormone in these patients. There's also the potential that pituitary hormone deficiencies may develop either after surgery or from the tumor itself, or following radiation, which may or may not necessarily be detected because some of these symptoms are very, very subtle. And so as a result, patients may not be treated for their underlying pituitary hormone deficiencies. There's also the possibility that under or over treatment of pituitary hormone replacement can also affect the patient's perception of how they feel. And finally, also patients who recover from surgery, just like any other surgery, there's also occasionally there could be some complications that can arise, which may not necessarily be identified early on. So in terms of recovery from surgery, I will hand the talk over to my colleague, Dr. Lil, who will discuss to you about the surgical aspects for patients following recovery from surgery.
Yeah, thank you, Kevin. I appreciate it. So I'm going to just discuss a little bit about the surgical recovery period. And, I like to think of it as basically 3 phases. So the first phase of recovery, and so if you click forward 1 slide or 1 click, Kevin, you'll see that this usually occurs in the first few weeks after surgery. And then after the recovery phase, patients, I call it the recharge phase, when they start to refill their batteries and are getting back to transitioning to normal life. And then finally, in the third phase, hopefully this is when patients are really enjoying the benefits of having treatment and the improved quality of life. But as the topic of this presentation implies, not everybody recovers the way they'd like. Certainly, this audience needs no introduction to the type of surgery that we usually perform for pituitary tumors, and it's called transsphenoidal surgery. This is a surgery where we use the nasal cavity and the nasal sinuses as the corridor to get to the tumor, and this has certain implications for the patient. Next slide. And if you click on that, Kevin, you'll see that this is the bony cella where pituitary that protects the pituitary gland. And so during surgery, we need to do work to get into this bony space. And that's called the sella turcica. You can see it's shaped like a saddle. Now these tumors are near some areas of high-priced real estate in the brain. And if you click on that animation, you'll see that as the tumor rotates around, you can see the nerves that control your vision and the carotid arteries. All of these structures we are very, very careful to try to avoid during surgery. But it could potentially be a cause of patients not feeling quite as they'd like to afterwards. So let's take it each phase at a time. So the recovery phase is the first couple weeks after surgery, and this is a list of what patients tell me. They tell me they feel tired, they have stuffy noses, they have some drainage from their nose, some sinus pressure, and because of all these things, they're perhaps not sleeping very well, perhaps there's some pain that's keeping them up at night, and they need to take time off from work, and they need a little help around the house. Generally these patients are up and walking around and able to shower and do some basic activities of daily living, but they don't feel quite like themselves during this initial recovery phase. Now, what I thought I'd do is just show you here some reasons why patients may not recover as fast as others. And one thing that we look at very carefully is what we call the number of patients that need to be readmitted to the hospital after they've had surgery and after they've been discharged once. And so we look real hard at this, trying to reduce the number of patients who need to come back to the hospital after surgery. And so what I've shown for you here is a recent series from our institution in 2018 and 2019. And so this is a list of some of the reasons why patients may not recover as they'd hope, at least initially. The most common reason used to be electrolyte imbalances in their blood. So that's that row there that says delayed hyponatremia. Fortunately, we've developed new techniques of managing patients where that has virtually gone away. The other reason you may have heard about is called brain fluid leakage out the nose, so cerebral spinal fluid leak. That can happen after surgery, but unfortunately that's becoming less and less common also as the surgical techniques improve. Bloody nose is also a reason that patients infrequently come back to the hospital, and that's the row there that says epistaxis. So those are some of the, I guess, more important reasons that patients may need to come back to the hospital. Next slide. So this is general advice for patients after surgery to really optimize their recovery during the recovery phase. So we ask them to stop, hold blowing their nose, even though it's really tempting, of course, to blow your nose, to avoid straining, to keep up with your nasal washes, to irrigate out the blood products and the crust that form afterwards. Make sure to walk a little bit each day and to keep up with your pain control. So, the tendency is some patients really want to just try to tough it out afterwards. But I encourage patients to stay ahead of the pain. Always keep a little bit of pain medication on board around the clock, especially during the first few days and maybe the first week of surgery. It really helps patients feel better and recover faster. Next slide. So during the next phase, I call the recharge phase. And, surgery really does drain your batteries. It drains your energy. It does require general anesthesia. And, there's the stress of that experience, not sleeping very well. And so in this next phase is the chance to really have that restorative sleep, to really charge those internal batteries and get back to the activities that you enjoy. You're doing your activities of daily living, you're walking. During this phase, make sure to attend your follow-up appointments, get your hormone checks, and we'll often have an MRI scan at some point here too to confirm the amount of tumor that's been removed and to check for any other related issues. Next slide. So during this phase, this is what patients tell me, that they usually require frequent naps, that normal activities tend to tire them out easily. Even going to shop at the grocery store or taking a short walk around the block. Normally that wouldn't tire the patient out, but in this phase, those activities really can. They may have mild headaches at this point, some nasal congestion still, that's really common. But most patients at this point have a really positive outlook because they feel like they've turned a corner. They've gone back to work, at least part-time, and so they're starting to feel like they've been through the hardest part, and they're starting to enjoy life. Next slide. So I thought I'd spend a couple of minutes just talking about the nose, and the reason is because that is one of the determinants of how patients feel after surgery. It's the corridor that we use to get to these tumors. Patients tell me that after surgery they have a runny nose, they have some congestion, their sense of smell and taste may have been altered, and sometimes they can develop sinus infections as well, and if they do, that should be treated with antibiotics. This graph on the right, and I'll come back to it in a few slides, but this graph shows you the average score that patients give about the severity of their nasal symptoms. So we give them a survey to take after surgery. They score their nasal symptoms like congestion and headache, etc. And then this is the average score that's presented. We give it to them before surgery, so that's the baseline score. And then after surgery, the first week or the second week, you can see that the severity of their symptoms rises, and that's normal. But then by 12 weeks after surgery, the vast majority of patients are back down to normal. Next slide. Now, it's not surprising based on what we do that patients may have symptoms in their nose. This is a cadaver, and it shows you there in the middle how tight the corridor is to get in there. So it's not surprising there's some irritation to the nasal airway along the surgical corridor. Next slide. And this is a view of a cadaver, which shows you how crowded things are inside the nose. This is the right nostril, and this is a camera looking inside the right nostril. So you can see the area that we need to navigate. Next slide. And if you click on the video on the left, this shows you what the nose looks like 3 weeks after surgery. And this is a patient that had actually quite a bit of work done in the nose to perform the surgery. But you'll see that on the left side of your screen, there's some yellowish material. It's a little bit of red. It's a little bit red and raw. That's pretty common after 3 weeks after surgery. And that explains why your nose is stuffy and why you have some drainage and maybe even a little bloody discharge. And then the video on the right side shows you the remarkable healing that occurs by 3 months. And you'll see on this video that the mucosa, which is the tissue that covers the nose on the inside, lines the nose on the inside, is nice and kind of red. And you see it's covering that entire surface that looked so raw before. Okay, next slide. So I wanted to get back to this slide to really reemphasize the point that this survey on the right shows you average scores. So this is what the average patient would report in terms of their severity of symptoms. But that's not everybody. So within this population of patients, there are some patients who have worse symptoms, and so that's why I just want to take the time to share with you the process for recovery. Okay, next slide. So the final phase after surgery, I sort of called it rejoice. And hopefully this is a time when people are really enjoying the benefits of having treatment. And the quality of life is improved because hopefully we've improved your vision if the tumor was causing trouble with your vision. Hopefully we've helped improve your hormone balance, particularly in cases like Cushing's disease and acromegaly. So patients are beginning to see the changes in their body that they had hoped to see. And perhaps they're losing some weight, their diabetes is under better control. And usually by this point, patients are back to work full time, they're back to normal exercise, and they're able to travel. Next slide. Now, some patients do after surgery have lingering effects. And if you click on that video on the right, Kevin, you'll see how close the pituitary gland is to some key structures inside the brain. Now, some of the things that can linger are persistent sinus infections. So the patients can have a sinus infection that's treated, but then perhaps one can come back. So that can require some maintenance and treatment that can sap people's enjoyment of their quality of life. Fortunately, the loss of smell and taste, at least permanently, is uncommon, but it's possible to have a permanent loss of smell and taste, which certainly could affect your enjoyment of food. Chronic headaches, fortunately, are uncommon. I'll talk about them in a little bit in one of the forthcoming slides. Now, unfortunately, there can be some permanent complications as a result of surgery, and if that happens, it's usually with tumors that are quite complex. They're large. They're surrounding these critical structures like the nerves that control your vision or the carotid artery. And so it is possible to have these complications like vision loss or stroke. Fortunately, not very commonly, but those can significantly impact patients' quality of life. Next slide. So this is an illustration out of one of our classic medical textbooks written by Dr. Netter. And it shows these places in the nose that are responsible for the sense of smell. And that's the area that's shaded there in blue on the left side. So you can imagine, since we're operating around this region, that it is possible to affect taste and smell. As I mentioned, it's good that it's typically not permanent, but it can be, and that could affect your enjoyment of life. Next slide. Now, as I mentioned to you, the nasal corridor is how we reach these tumors. This is an event that can happen where the MRI that you see on the left side, the arrow is pointing to the sphenoid sinus, so that's one of the air-filled sinuses in the nose. And the dark space means it's open to air, and that's the normal situation. On the right-sided panel, after surgery, sometimes the flow of air and the natural flow of the secretions inside the nose gets blocked up, and so those secretions can build up, and those can cause headaches or even a foul sense of smell. And that's a condition called a mucocele, and sometimes that needs to be treated if it's causing difficulty. Next slide. So headaches are always a tricky one for the medical community to evaluate. There are many causes of headaches, and in my experience, patients who have headaches after surgery typically are patients who have a chronic headache condition, and the surgery just sort of exacerbated that underlying condition. It's very uncommon to have new chronic headaches, but certainly possible. And in fact, most patients who had headaches before surgery notice an improvement in those headaches, and that's very common with a condition called Rathke's cleft cysts. But the causes of chronic headaches in this population could be the following. It could be exacerbation of a pre-existing headache disorder. These patients could have chronic sinus disease, like some of the things I showed you that can cause headaches. They might also just have poor sleep or sleep apnea, which can exacerbate headaches. Sometimes we just don't know what is causing their headaches. I showed a picture here of Dr. Knievel. She's a headache expert at our center. And so I would highly recommend, after the surgeon and endocrinology team have evaluated potential causes from headaches, at least from their perspective, that a headache neurologist, somebody who specializes in that field, can be very helpful. Next slide. So here is a list of tips to how to optimize your recovery. This is like the to-do list. Maintain exercise, at least go on a walk a few times a day. Maintain good body weight, avoid smoking. Tight control of your blood sugar is helpful. Headache control we spoke quite a bit about already. Seek an experienced team of providers who has a lot of experience taking care of patients like you. Make sure to take your medications and go to your follow-up appointments. And I really can't stress enough the importance of getting back to your normal routine as soon as you can. When patients are home trying to recover and they're not in a normal routine, a little bit of depression can set in because they feel like they don't have a goal. And so once you get back to your normal routine, you're getting back to work, you feel like you have a reason to get up in the morning, you're back into your regular cycle. That's a really, I think, important advice, very helpful for patients as they recover. All right, next slide. All right, I'm going to turn it back over to Kevin. Thank you.
Thank you, Andrew. So what I'm going to do in the next few minutes is to just maybe give you some published studies of what other common symptoms that can arise from patients after having had treatment, either surgery or medical treatment. So this is one such study that they looked at the types of different symptoms that was reported by patients fairly soon after surgery. This is like 1 month after surgery, and you can see here the green arrows that you can see on the left-hand side essentially represent an improvement in those particular symptoms, like the fatigue, the memory, the vision. But interestingly, you'll see that the thing that can actually get worse, or at least is often reported, is the sleep, the disturbed sleep. And on the right-hand side here, you can see the severity of the sleep tends to get a little bit worse within the first month. And I think it's probably not surprising, given that some of patients after having pituitary surgery may have some inflammation, as Dr. Lil has just mentioned to you, and the nose gets inflamed and maybe a little more difficult to breathe at night. And so this can sometimes affect the sleep as well. And then if you move along to somewhat a little bit longer than 1 month to 3 months, and this is another study where they looked at obtaining the types of symptoms that patients report, you can see that headaches can sometimes still persist. As Dr. Lil had mentioned earlier, sometimes the headaches can sometimes persist. And also the issue of smell, the olfactory impairment is also another factor that patients can sometimes report as well. Nausea and vomiting is common, usually not life-threatening unless during the course of the surgery or even before, if the patient has underlying diabetes insipidus, and if they continue to have nausea and vomiting, particularly vomiting, that can increase the likelihood of dehydration and raise the serum sodium levels. So that can sometimes be a problem. Tends to be more commonly seen after surgeries with a craniotomy rather than a transsphenoidal surgery. And the nausea and vomiting generally has a low incidence with the transsphenoidal surgery than craniotomy. Could be due to the lesser invasiveness of the type of surgery. And also when you have a lesser invasiveness, then there's generally a reduction in inflammation and pain as well. So risk factors for nausea and vomiting include leakage, fat grafting, and sometimes lumbar drain placement. And the incidence can occasionally be more often seen if the patient has leakage, a CSF leak, in patients with acromegaly, prolactinomas, and non-functioning tumors, more so again in this study reported than those patients with Cushing's and apoplexy. Larger tumors may lead to greater surgical manipulation that, no surprise, can may aggravate some of the nerve endings in the nose and also in the skull base, and that can sometimes aggravate the nausea vomiting. Disorders of water metabolism is a very commonly reported reason for hospital readmissions after surgery. Could either be diabetes insipidus or the other condition, which is called syndrome of inappropriate ADH. This can be generally caused by the direct manipulation of the from surgery, or occasionally with the tumor itself that affects the production of the hormone called vasopressin, which controls your drinking and your urination. It can be partial, or occasionally it can be total, and it can be sometimes transient or permanent. Thankfully, this is very rare following surgery. Diabetes insipidus is where there is a reduction in vasopressin, the hormone that is produced from the posterior pituitary, and that can lead to excessive thirst and urination, which, as you can imagine, if you're urinating many times, that can affect your sleep. You're tending to wake up more often. And it can occur roughly between 10 to 30% after surgery, and can, thankfully, as you can see here, persistent only in about less than 10%. SIADH is the opposite, where you have inappropriate secretion of vasopressin that results in low sodium levels, which can cause patients to, after surgery, report of headaches, some degree of confusion, fatigue, drowsiness, restlessness, irritability, muscle weakness. And you can see here the first 5 or 6 symptoms are actually really non-specific symptoms, which patients sometimes may not necessarily know that this is caused by the low sodium. Obviously, the more severe symptoms would be seizures and cramps, and that usually then would lead to hospital readmission. It tends to occur again within the first 5 to 8 days after surgery, and typically it tends to be transient. Hypopituitarism, which is basically a reduction or deficiency in pituitary hormone production, can sometimes develop before surgery as a result of the tumor itself causing a reduction in these hormones being produced, or after surgery. Thankfully, again, this observation is actually rare. And again, here you can see here, these are the published articles describing the incidence of hypopituitarism following surgery, again, which is generally less than 10% in the hands of a multidisciplinary team with an experienced surgeon. The risk of developing hypopituitarism, again, relies on many factors, but you can see here some of the lists that I've just listed here: neurosurgeon experience, how big and the tumor is, the consistency of the tumor, and also the type and the location of the tumor as well, which then dictates the extent of the surgical manipulation. And obviously, the more surgeries are being performed, then that also could have a cause into more likelihood to developing hypopituitarism. Rates are again reported to be higher in patients with Cushing's disease. I suspect largely because maybe there is an increased use of steroids after surgery, or if there is underlying growth hormone deficiency or underlying hypogonadism in patients, then the rate tends to be higher after surgery. Some recovery of the function can occur after the surgery, and this has been reported in several studies. Mainly, the thyroid function can recover about a third, followed by the male and the female gonadal axes as well. The recovery of the steroid, or what we call the HPA axis, the cortisol axis, tends to be more likely in patients with acromegaly versus those with non-functioning tumors. But like I mentioned to you earlier, if there is underlying hypopituitarism and if the hormones are not adequately replaced, that can obviously affect the quality of life as well. So this is a very recently published study from a Dutch group where they looked at asking two questions. One is to see what kinds of psychological complaints that patients with hypopituitarism report of after they have been adequately replaced at least for 6 months of their pituitary hormone replacement. And then the second question they asked is to see whether how these patients identified their illness or how they perceived their illness to be, and to what degree that their illness, in this case hypopituitarism, causes their psychological complaints. So there's a group of 42 treated hypopituitary patients. They had at least 1 to 5 pituitary hormone deficiencies, and majority of them, almost 90% of them, had 2 or more pituitary hormone deficiencies. And the tumors that these patients had were non-functioning adenomas, craniopharyngiomas, acromegaly, Cushing's, and prolactinomas. And what you can see here on the lower graph is that the fatigue tends to be the most common, followed by sleep and memory issues and mood issues. And then on the right-hand side, you can see here that there's also about 20% or so of patients who can report or some degree of functional impairment as a result. Now, when they looked at comparing these rating scores of patients with hypopituitarism compared to those with diabetes, asthma, colds, and patients with heart attacks, you can see that at least in some of these psychological symptoms, that patients with hypopituitarism did report an increased perception that their hypopituitarism was the cause of why they felt generally lousier. This is a study where they looked at patients with acromegaly who, again, as you know, most patients with acromegaly are treated with surgery as their first line of treatment. So they looked at surgically treated patients, and then they compared those who were in remission following surgery versus those that were not in remission, therefore requiring additional medical therapy. And what they found from the findings was that when compared to healthy controls, quality of life remains poorer in those treated with acromegaly compared to healthy controls, and that medical treatment for those patients who were not in remission after surgery achieved comparable quality of life to surgery, which may be associated with better quality of life in certain physical subdomains, as you can see here on the right-hand side. So in general, patients with acromegaly after surgery, these patients can sometimes report impairment in quality of life mainly due to psychological issues following the even after what appears to be a successful surgery and biochemical remission. So again, the reason being is that many of these patients, there's a delay in their diagnosis, which can cause irreversible damage to many parts of the body. As you can imagine, growth hormone receptors are located in practically almost every organ, as you can see here. So there could be changes that can occur in these organs over time. Especially pain and fatigue does affect the mental state of these patients as well, and that can often lead to depression. And also the other issue as well as physical disfigurement as well. Patients can also report of impairment in sleep quality, which can initially worsen after surgery but tends to recover over time. And despite biochemical remission, sometimes these symptoms can continue to progress, especially in those who have received radiotherapy or who are not adequately treated for their underlying hypopituitarism. Switching gears to patients who have Cushing's disease, and again, you can see here, this is a study from 2019 where they looked at patients before and after surgery in comparison to those with non-functioning pituitary adenomas. And again, not surprisingly, you can see that the higher the score, the worse the depression is, and you can see that the dark columns represent patients with Cushing's before and after surgery when compared to non-functioning adenomas, and controls generally have greater severity of depression as well. Again, the reason could be multifactorial, physical symptoms, which may not necessarily reverse and can occasionally take longer than what the patient expects. So the weight, the fatigue, the skin issues that come along with having Cushing's. The fatigue also obviously affects the psychology and the mental state of the patient. So the patients may not necessarily are able to do what they were able to do in the past. And also then there's also the effects of cortisol on organs like blood vessels, liver, and the brain. So therefore, understanding and encouragement by healthcare providers, and in some cases psychological support, can sometimes help navigate these patients through this difficult period. One of the more common issues that can occur either before or even after surgery in patients with pituitary diseases is adrenal insufficiency. And that can sometimes occur after a mean period of roughly 15 months for patients with Cushing's. And occasionally, these patients who have had adrenal insufficiency for a long period of time, they tend to be younger at age, and they may have had the disease for a longer period of time that was not diagnosed. And as a result, after successful treatment for the Cushing's disease, be it surgery or radiation or medication, they can develop what we call glucocorticoid withdrawal symptoms, and that can sometimes be often confused with an adrenal crisis. They might feel weak, fatigued, lack of appetite, weight loss, nausea, vomiting, diarrhea, and the mechanism is unclear. And if the patient has been given steroids, then the recommendation is to consider a slow tapering of the steroids to hopefully mitigate and reduce the severity of these symptoms. They are often self-limiting, and if these symptoms worsen, occasionally an increase in these steroids could be considered, followed by a slow tapering. So the prevention of adrenal crisis is crucial. Counseling is crucial. Patient has to be counseled to be aware of the illness and to consider stress dosing. In situations where they are unable to swallow the tablet because of vomiting, swallow the hydrocortisone or prednisone tablets, then they should get the steroids either IV or injections, or they may need to go into the hospital to get these medications. But I think it's important to also set the expectations and counsel the patient and the family and what to expect if the patient truly has adrenal crisis and how to handle this or how to prevent it as well in many cases. Prolactinomas are typically treated not with surgery as the first line, but with a medication called dopamine agonists. And however, just like any medications, dopamine agonists can have side effects too, which should be explained to the patient. So if the patient is taking these medications, they can sometimes develop nausea, vomiting, heartburn, low blood pressure, which then causes dizziness, and also in rare occasions there have been reported cases of compulsive behaviors as well. There's also a previous article that published that found an association where if the prolactin levels were higher, the higher the prolactin levels, the poorer the quality of life, as is shown in this figure here on the right-hand side. So what do we mean by personalized medicine? So given that many patients, every patient is different, the concept of personalized medicine is now increasingly adopted for disease treatment and prevention that takes into account of individual variability in terms of the patient's genetic makeup, environment, and lifestyle of each person. And this contrasts to the one-size-fits-all approach where treatment for diseases are developed for many individuals and less consideration for specific individual patient circumstances. So in the context of pituitary patients, precision medicine is encouraged or should be adopted to effectively address the different types of treatment and symptoms that patients can report, to take into consideration of the individual variability, especially in terms of the types of different tumors that can present, be it big tumors or small tumors, functional or non-functional, imaging characteristics, and genetic makeup, and also individual patient circumstances. So in order to achieve personalized medicine, it's important to adopt a multidisciplinary team approach because as you can see, the symptoms that patients report with treatment of pituitary diseases is so variable, and that a multidisciplinary team approach is often required to effectively manage these patients. So to conclude, transsphenoidal surgery, or surgery for that matter, through the transsphenoidal route is a relatively safe procedure, especially in the hands of an experienced surgeon, and this is well documented in the literature. Transcranial approach rarely is performed, especially for those tumors that are large and invasive, where the transsphenoidal approach may not be a viable option in this situation. Post-op management often requires a multidisciplinary team approach. And as Dr. Lil mentioned earlier, most symptoms after surgery resolved in the short term, but unfortunately, there's still a proportion of patients that may require lifelong surveillance and treatment because of the fact that the disease can still recur, or the disease is not in remission, and patients may have a variety of symptoms that need to be managed effectively. In patients with hypopituitarism, acromegaly, and Cushing's disease, despite adequate hormone replacement for those with hypopituitarism and adequate treatment control for patients with acromegaly and Cushing's disease, some patients can still experience problems with daily living, which include negative mood states and a decreased psychological well-being, and that requires close attention and management, again, with with a multidisciplinary team approach. So with that, myself and Dr. Lil will be happy to answer any questions, and I thank you for your attention.
Thank you so much, Dr. Ewan and Dr. Little, for a very valuable presentation. We do have a few questions that I will read to you, and then you can answer individually. Our first question is, I just had my third pituitary surgery at UVA April 22nd and radiation on August 19th. My IGF-1 is only 48. Will this get any better?
I'll take that. So it looks, so IGF-1 levels are dependent on age and gender, but your IGF-1 of 41, without knowing your age, but 41 sounds like it's quite low anyway. So even given the fact that you've had 3 surgeries and radiation, the odds are against the fact that your IGF-1 will improve following such treatments, and therefore the possibility of having underlying growth hormone deficiency should be entertained and considered, and perhaps even treated as well. So it's unlikely to improve over time.
Okay, thank you. Our next question is from earlier in the slides. During recovery, there are no signs of adrenal insufficiency. I noticed the chart said 0.0 and just wanted to confirm. Thank you.
Andrew, you want to take that?
Sure, no, thank you for the follow-up question. Yeah, so that was a slide that reviewed the causes for readmission to the hospital. And so in that particular cohort of patients, there are no patients that required readmission for adrenal insufficiency. So that's an important distinction from, there are patients who can develop adrenal insufficiency from surgery, but what we do is we screen them while they're in the hospital right after surgery to detect those. And once we detect them, then we treat them with steroids so that they don't come back to the hospital with adrenal insufficiency.
Okay, thank you, Dr. Little. The next question is there a test that can be done to detect levels of the hormone that causes diabetes insipidus when deficient?
Yes. So diabetes insipidus is a condition where, as I mentioned to earlier, is characterized by excessive drinking and excessive urination. So the short answer is yes, a test can be done, but in order to do a test, one needs to get a history from the patient in order to ascertain whether the patient truly has excessive thirst and excessive urination or not. Because often after pituitary surgery, where the surgery is done through the nose, sometimes the nasal mucosa gets dry, and many patients may be breathing through their mouth. So they may feel that they are thirstier when actually what they are doing is that because of the dryness their nasal mucosa, and especially in Arizona where it's so hot together as well, you'll see that they may get a sensation that they are drinking a lot more often. So I think the first thing to do is to assess and ensure that that there is excessive drinking involved and excessive urination, and then you can proceed to do a test which to confirm your diagnosis of diabetes insipidus. And that can either sometimes be a simple, straightforward test of electrolytes and perhaps urine and serum osmolality, a blood test, following maybe say an overnight where the patient hasn't been drinking, and if it's very high in terms of his sodium and very low urine osmolality, that sometimes makes it very likely that the patient has diabetes insipidus. Occasionally, when the diagnosis is not so clear-cut, then occasionally we may have to bring them in and perform what I don't like to do, which is the test called the water deprivation test, where you essentially you deprive the patient of fluids and closely monitor them and continue collecting their urine and blood tests every hourly to see whether they're able to concentrate that urine or not. following water deprivation, and if the urine concentration occurs without any medication on its own with water deprivation, then the condition of diabetes insipidus is unlikely.
Okay, thank you. The next question says, I am 2 weeks post-surgery. What purpose does the steroidal medication post-op do?
Again, it depends on different centers or where you go to. There are some centers, including ours, where we don't routinely prescribe steroids after surgery unless the serum cortisol levels are below a certain level, which suggests that the patient has cortisol deficiency, and only then that we would prescribe steroids. Occasionally, I've heard that there are also some centers around the country where they routinely provide steroids after surgery, just to cover the possibility that the patient may have adrenal insufficiency following surgery. And if that's the case, then they should be retested typically after 6 weeks of surgery to see if they truly have adrenal insufficiency or not. Because if they don't, then there's really no point in continuing with the steroids if they don't have adrenal insufficiency.
Okay, thank you. We have another question. If a patient does not lose weight following surgery to treat Cushing's disease and biochemical remission, is that indicative of a problem?
Not necessarily. Weight loss would be very nice to see if the surgery or if the treatment has been successful for Cushing's, but occasionally losing weight sometimes takes longer than what patients anticipate. So it may not necessarily be a bad thing if you don't lose weight. Ultimately, the important thing is to do further testing, like a urine test or saliva tests following surgery, to determine if the patient is in remission after surgery or not. But if there is concurrent weight loss that occurs at the same time, then that's great. But there are occasions where the weight doesn't necessarily come off that easily, and that doesn't mean that the surgery has failed. So again, we have to further assess and further test in order to see if the status of the disease is in remission, or whether the disease is still persistent. And weight loss helps, but it's not essential, because sometimes patients don't necessarily lose with that weight very easily.
Okay, thank you. And we do have quite a few questions, so I'm going to read 2 more, and then the rest I will save an email if that's okay with you, and we can get the answers back to our patients.
Okay.
Our next question is, how long should a patient expect their cortisol levels to become normal after pituitary surgery for Cushing's, and what type of treatment would there be if it remains low?
So Dr. Little and I, we have a protocol for surgery for patients with Cushing's, meaning after undergoing surgery, we measure cortisol levels closely within the first, after 6 hourly for the first 24 hours, or occasionally it could be down to 3 hourly. And the idea is to track these cortisol levels to see what the status of the condition is after surgery. If the cortisol levels drops, certainly in our institution, if it drops below 1.8, then we would consider starting the patient on hydrocortisone before we send the patient home. And so in order to maintain the hydrocortisone, we often tell the patient that the patient needs to stay on that hydrocortisone, typically a slightly larger than average dose, usually about 60 milligrams a day, because when the cortisol levels drop so quickly, patients can sometimes feel unwell, what we call the glucocorticoid withdrawal syndrome. And so they go home on a higher dose, and then we counsel and we coach them to gradually taper the dose very slowly downwards over the next few weeks before we see them again in clinic in about 6 to 8 weeks, and retest them to see if they truly need to remain on hydrocortisone or steroids or not. Usually if the levels are very low immediately after surgery, the indication is that they will probably need to stay on steroids for a few months, and occasionally sometimes can be up to a few years as well. So it's very important that patients are given steroids if their cortisol levels drop and remain low after surgery, because patients don't feel well because of the fact that their cortisol levels are very low, where their body is not used to the low levels after having had high levels for such a long time before surgery.
Okay, thank you. And our final question that we will answer live: what are the risks of pituitary apoplexy?
Andrew, you want to take that?
Sure, that's a great question. So we think that the risk is very, very low. So, and I'm going to take the question to mean that it's a patient who has a known or an unknown pituitary tumor and has not undergone treatment. So they're either, it's a tumor that's unknown or one that's being observed. The risk of apoplexy, we think, is quite low. There are some risk factors. If patients take blood thinners, for example, that's one potential risk factor. So, you know, the way I counsel patients is if they have a tumor that we're following, I let them know that apoplexy is a risk. And for those who don't know, apoplexy means that there's sudden bleeding or death of the tumor that results in expansion or swelling of the tumor, and that causes headaches and can cause vision loss. Patients can rest assured that the risk of that is quite low, but nevertheless should be aware of those red flags and come to the hospital if it happens.
Okay, thank you guys so much. Thank you, Dr. Little and Dr. Ewan. It was an amazing presentation, and that will conclude today's webinar. We really appreciate you taking the time to join us. And if you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. Again, any questions that were not answered, we will be emailing to the doctors and we'll respond as soon as we can. There will be a brief survey after the webinar. Please fill it out to help us provide you with any information that you need. And thank you for joining us, and enjoy the rest of your day.